I'd like to thank Monivent for giving me this opportunity to speak to you about the best attempt approach in management of the difficult neonatal airway. It's Dr. Alok Sharma, and I'm a consultant neonatologist working at the Cornish Hospital. I have no plans to declare. I'm going to spend some time speaking to you about differentiating the difficult neonatal airway from difficulty in managing the neonatal airway. This is a concept that's not been extensively covered in the literature. At birth, approximately 10% of babies need airway breathing support of some kind. About 5% of these babies will need airway management with either IPPV or intubation, and a small proportion of these babies will present with difficulty in management of their airways because of an underlying anatomical or physiological problem with their airway and the heart lung system. Now, by definition, the difficult neonatal airway has been defined by the American Society of Anesthesiologists as an inability to mask ventilate or intubate a baby. Now, when we talk about intubation, the issues are usually either difficulty visualizing the glottis, as might be the case with a baby who has Pierre-Robin, or ability to visualize the glottis, but a difficulty passing an ET tube through the cords, as might be seen with babies who have subglottic stenosis. Now, clearly, when we talk about the difficult neonatal airway, by definition, the assumption is that there is something wrong with the baby that is making airway management a challenge. There is, however, difficulty in management of the neonatal airway, which might occur because of problems with the skill set of the team attending the delivery, the absence of working or available equipment, or human factors issues where communication and behavior influence the management. And they may also contribute to difficulties with management of the airway, which I believe are easily correctable. They can actually be prevented by simple use of a checklist. These are completely avoidable problems which the team can mitigate against. And really, if the team is able to mitigate against these issues, then if they have difficulty, you can then assume that there is something that is wrong with the baby. In fact, your first attempt should always be your best attempt. And if you have mitigated against issues of skill, of equipment failure, you have done crisis resource management training. There are huge benefits when you and end up in a situation of a difficult airway. So, what is the basic assumption? The basic assumption is that as individuals, we train in neonatal life support algorithms, and we intend to deliver resuscitation with the best of intentions with a view to producing a good outcome. Unfortunately, there are factors outside of our control that can affect our performance on the day, and that may result in an outcome that is less than optimal. So, a simple example that I'd like to quote to you, this is a hypothetical example of management of a baby who has to have a surgical procedure where we're electively intubating the baby. Now, clearly, you can see that there is a lot on this team's mind. So, the nurse naturally is preoccupied. The consultant has been up for 36 hours and does not know where his glasses are. But more importantly, the person who's managing the airway, an experienced registrar, has secretions and can't visualize the cords. But she's failed her previous three intubation attempts, and this is weighing on her mind. So clearly, there are thought processes outside of this which might actually compromise this team's performance. But this team has also not used a checklist, and for that reason, they have not checked whether the suction was working. It isn't. And the intravenous access has also extravasated, resulting in inaction of the pre-medications that have been administered to this baby. So actually, a failed intubation in this context is not the result of an anatomical or a physiological problem with the baby. It's a result of a lot of things that are going around, including human factors and the absence of preparation. And all of these factors can be mitigated against. In my opinion, this is not this team's best attempt. How do we manage difficult airways in neonatology? Well, a lot of the algorithms that have been produced in the literature have come from pediatric and anesthetic guidelines, which essentially focus on can't intubate, can't ventilate kind of approaches. Now, not only are these guidelines notoriously difficult to follow cognitively, I mean, as you can see, this guideline is extremely wordy, but to the untrained brain, the ability to then go through the pathway and read things in a situation which is quite stressful can be overwhelming. In addition to this, I would say that a lot of the difficult neonatal airway guidelines that are currently there in the literature don't always cater to the development of mental models in situations like this. And the focus in guidelines tends to be on limiting the number of intubation attempts, which I think is correct, but does not necessarily tell you or lead you to a pathway that says, what am I going to change about my next attempt at managing the airway? Now, the one thing I would like to warn against is that repeated failed attempts at intubation without an understanding of why or what you're going to change can result in glottic edema and can result in quite a difficult situation. So, the approach that we should develop should be one where we inculcate crisis resource management and develop simple pathways to try and make difficult airway management easy. This brings me to the best attempt approach. This is a quality improvement initiative that we implemented in Southampton University hospitals where I was previously working. The entire concept of the best attempt approach focuses on our ability to be able to manage the airway in making preparation in using a checklist. Now, the preparation is such that avoidable factors that may result in unsuccessful airway management have been addressed prior to the airway management attempt, whether that's mask ventilation or intubation, both. The important thing is that this helps prevent difficulty in management of the neonatal airway that might arise due to factors like the team composition, the skill set, uh, equipment, making sure that equipment is working, team dynamics. But more importantly, it means that the team is then prepared if they have difficulty managing the airway because they've failed to address issues of anatomy and physiology that might be complicating this intubation. That human factors is not really the issue in this particular attempt. Now, if teams prepare for this in their first attempt, then actually I would say your first attempt will be your best attempt. The important thing from our perspective is that when we talk about the best attempt approach, it is the right team that is managing this baby's airway, that is appropriate numbers with the right skill set, with their roles decided, uh, working with the right equipment, which is appropriate, checked, and working, having discussed a plan, so an intubation or an airway securing plan, but also discussed a plan that addresses intubation failure and escalation to the difficult airway pathway if they struggle. They should standardize the processes of escalation, that is, calling for help. So, who are you going to call and how are you going to call them? And my experience of putting this pathway in place has involved a lot of CRM training, but a lot of focus around issues of assuming leadership and communication between team members, which becomes quite critical in situations where intubation or airway management is becoming difficult. Now, how have we gone about developing the best attempt approach in Southampton? Well, as a first, the one thing that we wanted to do was optimize performance in both context of anticipated difficult neonatal airways, so where we might have an antenatal diagnosis of a baby who we, we predict might have difficulties with management. Alternatively, also looking at the situation where we have unanticipated difficulties in management of an airway, say an X23 weeker who's recently extubated after multiple intubation attempts, who has developed respiratory distress and stridor. The intention from our perspective was to standardize the teams and the approach that they would take, alongside standardizing equipment, standardizing the clinical approach of Plan A, Plan B, and following an algorithmic approach which addresses issues with difficulty in management with a simple flowchart that has pictograms in it. At the end of the day, the intention from our perspective was to teach teams to recognize difficulties with airway management. Say, if it was intubation, to recognize whether they're having difficulty with visualization, or difficulty where they can visualize but can't intubate the baby. Now, we've given them alternatives in how they manage that situation using a video laryngoscope. But if they're having difficulty trying to intubate a baby who might have a structural problem, then early escalation to our ENT team is the pathway that we tend to follow. And the important thing is we've standardized the approach in how we get to them as soon as possible. So how did we implement this training? Well, as a first part, what we have agreed whenever we have an anticipated neonatal difficult airway, or even a simple management of change of an endotracheal tube or intubation, is having a structured approach to how we go about preparing for this. And we do this in four phases. So the first phase is having a pre-intubation huddle, where the team, which is a standard four-member team, which I'll talk about, meets prior to the actual airway management attempt. Now, this may be, not necessarily intubation, might be just airway management that we're planning for, or PEEP, as we might do in an extremely preterm baby. But the intention from our perspective is that we check all the equipment and make sure that it's working, as well as prepare it for the urgency of the situation. So once this is prepared, the team meets and goes through a checklist which addresses certain issues, which I will discuss with you. But more importantly, goes through a roles, equipment, plan, action, escalation policy, which tends to prepare the team for the unexpected. Now, once we have discussed all of this, it's only then that the procedure starts and ensures that this attempt, our first attempt, should be our best attempt. Now, the important thing from our perspective is we use a checklist in this process. And as I discussed with you, we have standardized how we discuss this. We discuss any risk factors that might be there if this baby's previously been intubated. But we also know that babies who are extremely small can have multiple intubation attempts. And what we try to do as part of our quality improvement project is minimize the number of attempts that are needed for extremely small babies. Now, the reason we have put this in is because we want the most experienced team member intubating these babies as opposed to, I would say, colleagues in training. More importantly, what we get the team to do is go through what we call as REP, or roles, equipment, patient, and then discussing plan A, which is essentially the plan for airway management of the baby in that situation, but also preparing for the potential that they might have what I say is airway management or intubation failure, so a backup plan. Now, this is clearly a checklist where the roles of the team, the lead intubator, the assistant, who is going to administer medications if we're doing an elective intubation, but more importantly, which of these persons is going to have global overview and assume the role of a scribe and have oversight. So we go in with four-member teams. We prepare all our equipment and make sure it's working. This includes IV access, pre-medications, as well as making sure that we have a working laryngoscope with batteries and an appropriate size mask, all things that can complicate airway management if the equipment is not working. But more importantly, it's important that we confirm that we have appropriate monitoring in place, including keeping babies warm. This is quite important during the intubation process. Now, there's a question that I'm often asked whenever I teach on my difficult neonatal airway course, which basically talks about, well, how many team members are necessary when you're going for, say, a routine elective intubation. And I would say that in our setup, we use a four-member team, which comprises of a person who is lead manager for the airway, who we call Airway 1, followed by a second person who feeds back, uh, helps secure the tube, feeds back heart rate, and if there is bradycardia, can also help with compressions. This is Airway 2. We have an experienced nurse who helps administer pre-medications, and in my setup where I currently work, we have a respiratory therapist who also acts as a runner, but again can help with equipment if necessary. Most importantly, we have a fifth member of the team who acts as the person with global overview, who is a CPR coach and scribe. Now, he is supernumerary to the team, and the reason for this is he has global overview in a situation which I would call as a very high fixation event. It's quite essential that there is somebody who has global overview. Now, in setups where you will not have enough team members, my recommendation is that you should go in with at least three members of the team to be able to manage airway, breathing, but also to have somebody who can do circulation access and have an experienced nurse who can manage equipment. Now, in those teams, one of these three members would have to take the role of having global overview or being the CPR coach, and that role might change based on the roles of the other persons because my experience is the person managing the airway is often hugely fixated. What is important from our perspective is, well, what does the evidence say? Now, the evidence clearly from our perspective comes from a very nice randomized control trial that's been done by a colleague of mine, Nathan Sundgren, in Texas. And they looked at the effects of team size on a decision support tool, uh, looking at healthcare provider workloads in a simulated neonatal resuscitation. Now, in this randomized trial, a three-member team was much better at being able to manage workload, being able to manage cognitive load in a situation where a baby needs neonatal resuscitation as opposed to the minimum two members who are recommended by the NRP. I mean, this is something that extrapolates very much to the difficult neonatal airway situation. But what I would say is an additional member who can act as a runner, a scribe, and a CPR coach, I would say is also very important. I think when you talk about standardizing teams, you don't want to have too many people, as you can clearly see over here, where things can become quite chaotic. But really, the organization of the team around the baby also becomes quite important, in that this is a five-member team with Airway One and Airway Two, but everybody on one side, making it quite crowded and making it quite difficult for people to actually keep an eye on chest wall movement as well as the vitals. Now, what is important is that we have team positioning that is appropriate whenever we are managing the baby's airway. Now, in our setup, again, we follow a standard approach where airway one is at the head side of the baby. He's managing the airway of the baby. Airway 2, as we discussed, is the person who supports Airway 1 in confirming the endotracheal tube, helping fix the endotracheal tube. But more importantly, Airway 2 can also keep an eye on monitoring, keep an eye on the baby's heart rate and SATs, which Airway 1 can often not because this is a high fixation event. The reason I also want Airway 1 to focus on the baby is because I want him to visualize chest wall movement while he's providing IPPV or resuscitation, but also keep an eye on the baby clinically. Now, an experienced nurse being on the opposite side means we have less crowd, but the nurse can keep an eye on monitoring, help manage equipment, but also from our perspective, feed back to the team if she finds that the baby is deteriorating. Now, a fourth member of the team, who is the CPR coach or the scribe, tends to be at the foot end of the bed and or keeps a global overview of what's happening, so has that kind of helicopter view of the team. Uh, Coming to the next aspect, well, we have standardized our equipment, and all airway management, including intubation, takes place through equipment that is kept in our simple trolley, which focuses on airway and breathing. So everything for mask ventilation is kept in drawer A, and everything for breathing is kept in drawer B of the simple airway trolley. This comprises all sizes of tubes, as well as the laryngoscope and suction catheter device. In addition to that, we have everything for access and circulation in subsequent draws, which might become necessary if you're going into neonatal resuscitation in the delivery room. But really, this is uh, everything that is needed for a first intubation attempt. Now, should our team fail their first intubation attempt, they are encouraged as per our pathway to verbalize that they have failed their first intubation attempt using the simple airway trolley, but then to get the difficult airway trolley and get the difficult airway pathway. And our difficult airway pathway works on an algorithm that has been endorsed by the BAPM, which helps to formalize the plan B of the checklist, which we discussed in the pre intubation checklist, as well as thinking of plans C and D if we need additional help or a multidisciplinary team. Now, these pathways are designed with pictograms which allow the nurses to recognize the equipment. You might have a nurse who's never seen what a video laryngoscope or a CMAC looks like, or what a broad blade or a severed blade looks like. So we've developed pictograms for them, which are then color matched to our trolley, which has the equipment in those respective drawers. And the guideline is placed on the difficult airway trolley. It's a vertical guideline which cognitively allows for simple reading and allows the team to go through the pictograms to kind of decide what equipment they need, but also has standardized approaches to who and how to call with their telephone numbers. The most important thing from our perspective is it's kept in a standardized area of the unit, which is equidistant from all our intensive care units. But if a baby has a difficult airway in theater or up on the third floor of our hospital, we have a grab box which is kept just above this, which the team can take, which also has this pathway and a similar color coded instrument scheme. The trolley has four drawers. The first drawer again has everything that we need for simple airway management, but also has cuffed tubes and has soft ET tubes with a McGill's forceps if we want to alter the way we are going to perform our second intubation attempt based on the baby's anatomy. The second drawer has everything that we need for an intubation attempt that might use specialized blades, as you might need for a baby who has macroglossia. We use a broad blade, which is called a Seward. They all work with one single laryngoscope, which has backup batteries inside. Uh, this is followed by draw C, which basically has everything for management of the anterior airway, which is an LMA and an iGel. We have both in our trolleys, simply because some people prefer to use the iGel and some people prefer to use the LMA. My recommendation would be that you standardize to using the iGel, as it's quite easy. But it also has everything that we need for use of the video laryngoscope, the kaleidoscope, which means that if you have an airway that is quite anterior, you can then use the kaleidoscope to manage the airway in these circumstances. The final drawer is the drawer that is used by our ENT team for an emergency tracheostomy. So it has everything for an emergency tracheostomy kept in a sterile set with a backup and a Crickstat needle if you want to do an emergency needle cricothyrotomy in these situations. The pathway, naturally, from our perspective, uh, follows an ABCD approach, but the most important thing is for any baby where we suspect an airway abnormality, either which has very difficult visualization or a possible underlying structural problem, maybe subglottic stenosis or a tracheal stenosis, we have a pathway that escalates directly to our ENT team through a standardized number to get them to get their making airway safe trolley, which has a 2.2 fiber optic bronchoscope, which allows intubation, and a special device which is called the Brambrink endoscope, which allows intubation with an endotracheal tube on it. So really, it is a multidisciplinary pathway. Uh, Coming to what we're trying to achieve, well, by standardizing all these processes, I mean, our intention is that whenever we have our first attempt at airway management, we're successfully able to mask ventilate, uh, intubate a baby if appropriate with minimal problems. And I can't emphasize enough that we have a large number of babies who really don't need intubation. Now, in our pathway, we have provided our teams with the ability to be able to use non-invasive ventilation, Optiflow, as well as CPAP if necessary to manage babies after mask ventilation if they're breathing well. You know, a really important aspect of managing the difficult neonatal airway is making sure that you have that as an alternative, because not every baby will need intubation. But more importantly, if the team have had an attempt at intubation or airway management which is unsuccessful, the use of the checklist ensures that it is not because of a lack of preparation, teamwork, equipment failure, failure of suction, lack of equipment, or human factors. In essence, this first attempt was our best attempt. We encourage team members, if they're failing, to mentally model and verbalize the reason for why they're failing so that they can change what they're doing about these airway management attempts. More importantly, to mentally model and in our standard protocol, we follow the BAPM pathway. Once a person has had two attempts at managing the neonatal airway, they should mentally model why they're failing. And if they think that this is an anatomical problem, difficult visualization because of an anterior airway, or a structural problem like glottic edema, or a structural obstruction of the airway, label this a difficult airway, get the difficult airway trolley, and escalate to ENT. Furthermore, what we've done is standardize the approach of escalation to ENT. Now, in other setups who don't have ENT, that might be anesthetics. I think what we're trying to achieve at the end of the day is not something that's new. The best attempt approach has been used, I would say, by other industries in a long way. So in the 1920s, in United States, bank robberies were conducted keeping certain rules being sacrosanct, and one of them has actually been adapted to a very famous Hollywood movie, which talks about the top 10 rules of robbing a bank. And these are very much applicable to management of the difficult neonatal airway. So you decide to rob a bank. Well, you're going to manage a baby who might have a difficult neonatal airway. So have a plan A. So that's our plan A for the difficult management, airway management, our protocol. Have a backup plan, which is plan B, that's intubation failure. Establish clear communications, choose your partners carefully, and expect the unexpected. We'll use a checklist because this is going to help with all these situations. And then shit happens. Well, despite using a checklist, some babies will have a difficult airway because there's an anatomical problem. Don't get greedy. Well, I think this emphasizes the important aspect of please avoid repeated failed attempts at trying to intubate a baby, because actually that will result in glottic edema and make things worse. And then remember, shit happens again. I think this is my final point, and it comes back to hang up and know when to walk away, is that there are some babies who will have structural airway problems who we will try to manage, but they will die despite our best efforts. A baby with tracheal atresia, a baby who has upper airway chaos with an airway. I mean, these are babies who have very, very high mortality. So sometimes we prepare to the best of our abilities, but actually we can't save these babies. And it's important that we recognize that in some of these situations, a tracheostomy after extensive resuscitation might not be in the baby's best interests. So really, you need to hang up and you need to, know when to stop. At the end, I'm going to summarize by saying that when you're managing the difficult neonatal airway, having a standardized approach which uses a checklist and uses a pathway that does not produce cognitive ability and allows a team to go through the different steps with a clear escalation policy for management of the difficult airway can be life saving. And I mean, this is a baby who we managed with no neck. And this is a baby where we weren't able to intubate. And we've simply used an LMA to manage this baby, which we've strapped in using our pathway, which basically uh, recommended the use of an LMA with difficult visualization. I'm going to thank everybody.